All right, let's get started. So like I was saying, good afternoon. Welcome, everyone. Please take a look in the chat and complete the pre-session survey before we get this webinar started today, as it's required for any sort of continuing education credits. I want to welcome everyone on behalf of Project Firstline Rhode Island and the Center for Acute Infectious Disease Epidemiology at the Rhode Island Department of Health in partnership with CDC. Thank you all for taking time out of your busy day to join me today as we talk about measles in the healthcare setting and review some important infection prevention and control strategies. Today's session is a repeat. You may have seen us advertise it last year. And we initially launched this course, I think it was last spring, but given the current measles situation in the United States, we felt that it might be helpful to offer it again to all of you. Before we begin, I'd like to direct your attention to the chat and introduce Abby Anderson, who is our Project Firstline Rhode Island project assistant. Abby will be posting information for you throughout the webinar via the chat. As a reminder, this session is being recorded, and we do have the Project Firstline team behind the scenes in support of the webinar. We can take a minute if you'd like to introduce yourself. I saw some of those messages coming through the chat while we were waiting. You can tell us your name, where you're from, any other information you might find helpful. My name is Alexis Kearney. I am a practicing emergency medicine physician here in Rhode Island, and I serve as the consultant medical director for Project Firstline Rhode Island. Prior to attending medical school, I completed my MPH in the epidemiology of microbial diseases, and I have experience responding to outbreaks in infectious diseases in the United States, Asia, and Africa. I'm excited to be here today speaking with you about measles and what all of us can do to prevent its spread. So thanks for letting us know where you're coming from. If you're returning, thanks for being here again today. We're super excited to have everyone. Just a few reminders before we get started. Currently, everyone is muted. At the bottom of your screen, you'll see the Q&A box, so you can use that for any sort of questions you might have. We will try to have a brief Q&A at the end and try to address any questions if we have time. If not, leave your email and we can respond to questions you may have now or anytime after the webinar. And the chat box is available if you'd like to connect with our behind-the-scenes team or to share experiences and otherwise interact throughout the session. So these are the continuing education requirements, just to make everyone aware. If you would like to receive continuing education credit, this is what you need to do. So this session is approved for 1 contact hour by the Northeast Multi-State Division Education Unit, which is an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. So to receive your CNE, there are 4 steps that you must complete. Step 1, if you haven't already done so, please complete the pre-session survey prior to us starting the webinar. Please go ahead and take a moment to do that now if you haven't already, because it will close very soon. You need to attend the entire live training. The third thing is complete the post-session survey after this training ends. It will be emailed to you tomorrow. And then must complete the post-session quiz, and the link to the quiz will be emailed to you as well. For other healthcare colleagues who are here today looking for certificates of training or EMS continuing education or dental IPC continuing education, you just need to worry about steps 1 through 3. Step 4, which is the post-session quiz, is optional. We encourage you to use it, but it is optional. So while measles was once considered to be eliminated from the United States, we have seen a sharp increase in cases over the last 2 years. Overall, there has been a decrease in vaccine uptake nationally, which puts more people at risk of contracting the virus. Last March 18th, 2024, the Centers for Disease Control and Prevention issued a Health Alert Network health advisory to inform clinicians and public health officials of an increase in global and U.S. measles cases and to provide guidance on measles prevention. Measles isn't just a rash. It's an acute viral respiratory illness. It is very contagious. It does cause a whole body rash and flu-like symptoms, but it spreads easily and can be serious or even fatal for small children. Outbreaks of measles in healthcare settings do occur, and transmission to and from healthcare professionals continues to be reported. Healthcare professionals are considered to be at higher risk of contracting measles compared to the general population due to the fact that individuals who are infected with measles often seek medical care due to the severity of their symptoms, and they may not know what they have yet. Furthermore, measles is highly contagious and potentially under-recognized, particularly in the early stages of the illness, which leads to delays in patient isolation and diagnosis. So today we're going to talk about measles and the infection prevention and control actions that you guys can take in your healthcare roles. So here's our agenda. We've already done our welcome and introductions. Next, we'll review the learning objectives for today, discuss the history of measles, and provide a brief clinical overview of the illness. In the second half of the webinar, we'll talk about vaccine recommendations and infection prevention and control actions, and go over a few case scenarios before reviewing our key takeaways at the end. And then finally, we have a few announcements. We'll give you the chance to provide some end of session feedback and hopefully have time for a brief Q&A. So we have 5 learning objectives for today's session. Understand what measles is and learn about its resurgence in the United States. Learn how to rapidly recognize measles based on history and clinical presentation. Understand how measles spreads. Know the steps to take if there's an exposure with and without proof of immunity, and learn the infection prevention and control actions to help decrease the spread of measles. So we're going to talk about a brief history of measles in the United States, and then talk about what we're facing right now. So before the live measles vaccine was licensed in 1963, there were an estimated 3 to 4 million people infected with measles annually in the United States. Most of these cases were not reported to any sort of health body. Historically, measles was a childhood illness, and most people contracted it by the time they were 15 years old. Despite it being a nationally notifiable disease in the United States since 1912, only about 549,000 measles cases were actually reported annually. Of these, approximately 48,000 required hospitalization, 1,000 developed acute encephalitis, and 400 to 500 people died annually from it. In 1968, there was an improved live measles vaccine that was licensed. And finally, in 1971, the MMR vaccine was introduced. So the MMR vaccine is for measles, mumps, and rubella and provides protection against all 3 illnesses. In 1989, the United States and other countries around the world saw an increase in cases due to low vaccination rates. This was due to an uptick in vaccine hesitancy due to widespread misinformation about the safety of the vaccine. In the year 2000, after significant work by public health officials to increase vaccine uptake, measles was declared eliminated from the United States. We'll discuss a little bit more about what elimination actually means on the next slide. But since the year 2000, the annual number of cases has ranged from a low of 37 in the year 2004 to a high of 1,282 in 2019. Now, historically, over the last 2 decades, the majority of cases in the United States have been among people who are not vaccinated against measles, and most were linked in some way to imported cases of measles, meaning that the individual contracted measles while visiting another country, and then when they returned to the United States, the virus spread amongst their contacts, generally to other unvaccinated individuals. Since measles is so contagious, it quickly and easily spreads in communities with large groups of unvaccinated people. Over the last year, we have seen a significant increase in measles cases across the country, leading epidemiologists and health departments to worry about sustained measles transmission within the United States. So the World Health Organization defines measles elimination as the absence of endemic measles virus transmission in a defined geographical area for at least 12 months or longer in the presence of a well-performing surveillance system. Measles was declared eliminated, like we talked about, in the United States in 2000, meaning that there was no measles virus spreading within the United States, and new cases were only found when someone contracted the measles abroad and then entered the United States. And this was really due to widespread vaccination campaigns, both in the United States and internationally. However, we have seen cases that were brought in by travelers, and it can spread and cause outbreaks among people who aren't vaccinated. So while the term elimination does not mean gone forever, the rapid rise in cases over the last 2 years does pose a threat to the United States losing its elimination status. So why are we talking about measles? Why has it been getting so much attention among kind of healthcare providers and the general media? And why is it a concern? So a decrease in measles vaccination rates globally means it can relate to an increased risk of larger measles outbreaks worldwide, including in the United States. But let's take a step back and define what an outbreak is. It's when a disease occurs in greater numbers than expected in a particular area. So measles outbreaks have been increasing worldwide, as we've talked about, mostly among individuals who are not vaccinated. When measles enters into communities of unvaccinated individuals, outbreaks occur. And in recent years, we have seen outbreaks linked to travelers from pretty frequently visited countries, including the Philippines, Ukraine, Israel, Thailand, Vietnam, England, France, Germany, and India, where we have had very large outbreaks. So this is a slide showing the number of measles cases reported by year in the United States. And I got this data off the CDC website as of last week. So as of April 24th, a total of 884 confirmed measles cases were reported across 30 jurisdictions within the United States this year. There have been a total of 11 outbreaks, which are defined as 3 or more cases in a geographic area, and 93 of confirmed cases are outbreak associated. So for comparison, 16 outbreaks were reported last year in 2024, of which 69% were outbreak associated, and only 4 outbreaks were reported in 2023. So what do we know about the 884 cases we have seen this year? So about 30% are under 5 years old, 38% in the 5 to 19-year-old range, and another 30% were older than 20 years old. The vaccination status, so the vast majority, 97%, were either unvaccinated or we didn't actually know what their vaccination status was. And a total of 11% of these cases required hospitalization. The highest risk for hospitalization was in the under 5-year-old group. And unfortunately, there have been 3 confirmed deaths this year. 2 were in unvaccinated school-aged children in Texas who did not have any known underlying medical conditions. And there was a 3rd death confirmed in New Mexico in an unvaccinated adult. And it's important to realize that these are the first reported deaths in measles in about 10 years. So the most recent death prior to this year was in 2015 in an immunocompromised adult. And prior to that, there were 2 deaths reported in 2003. So this graph reflects the number of measles cases reported in the United States, broken down by week from January 1st, 2023 through last week, through April 24th, 2025. And you can see that in January 2023, there were very few cases reported each week. We saw a small uptake in 2024, but since the start of 2025, we've seen considerable increases. And these are the 30 jurisdictions that have reported cases since the start of this year. And the darker the blue means the more cases have been reported in that area. So here is our first poll question. Measles cases have increased globally due to A, decreased supply of vaccine, B, decreased vaccination rate, C, decreased efficacy of the MMR vaccine, or none of the above. So the correct answer, excuse me, is B, decreased vaccination rates. All right, so let's talk about a clinical review. Let's have a brief clinical review of measles here. So the timeline is an essential piece of information to collect when suspecting measles. So after exposure to the measles virus, there is an incubation period of about 10 to 14 days, during which time the exposed person is asymptomatic. So around 2 to 4 days prior to the onset of rash, the prodromal symptoms begin. So this is the fever and at least one of the 3 C's, so cough, coryza, and conjunctivitis. Following these prodromal symptoms, the rash begins. And when we're talking about measles, the date of rash onset is considered day 0 when we're talking about a patient's clinical course. On average, the time from exposure to rash onset is 14 days, but it can extend up to 21 days. And people who contract measles are considered contagious from 4 days before to 4 days after the onset of rash. And this is really important because it informs isolation and exclusion policies for those who develop measles. And as you might imagine, the challenging part of measles control is that people are infectious before the rash begins and can be infectious when they only have really non-specific symptoms that look like any other respiratory virus: cough, fever, generally feeling unwell. So as we talked about, common symptoms include high fever. So this fever can be as high as 104 or 105 degrees Fahrenheit. And the 3 Cs, so cough, coryza, which is fancy word for runny nose, and conjunctivitis, red, watery eyes. So there's also classically a diffuse maculopapular rash, and then some people will develop white spots within the inside of the mouth, and these are called Koplik spots. We have some pictures of Koplik spots here. They're characterized as a cluster of white lesions that appear inside the mouth, typically 2 to 3 days after symptoms begin. They're sometimes described as appearing as if it is a grain of salt on a reddish background, and they occur prior to the skin rash developing. So the rash starts on the face, near the hairline or behind the ears, and it spreads downwards to the neck, trunk, and extremities. It is maculopapular, so small, raised, or flat red bumps that may become conjoined or coalesce as the rash spreads. Typically not itchy, and it does fade in the same order in which it appeared. So we have another poll question. What is the typical presentation of a measles rash? A, starts at the trunk and spreads up to the hairline and extremities. B, starts at the extremities and spreads everywhere, including the palms and soles. C, starts at the hairline or face and then moves down to the trunk and extremities. And D, the rash appears in no pattern. All right, so starts at the hairline or face and then moves down to the trunk and extremities is the correct answer. Complications may arise in people who have contracted measles. And the most common complications are diarrhea, otitis media, which is a middle ear infection, and pneumonia. And these complications can cause substantial morbidity. In particular, measles pneumonia can cause severe illness in infants and immunocompromised individuals. There are more severe complications. About 1 in 4 cases will require hospitalization. Encephalitis will develop in about 1 in 1,000 cases, and unfortunately, death can result from anywhere from 1 to 3 per 1,000 cases. The complications are all much more common in 2 main age groups. First age group is those under the age of 5, and the second is those over the age of 20. I also wanted to mention the last complication listed on the table here, which is actually a delayed complication, meaning that it happens years after recovery from the virus. Subacute sclerosing panencephalitis. This is rare. It occurs anywhere from 7 to 11 per 100,000 cases, but it is a devastating neurologic complication that occurs about 7 years after measles infection and is much more common among those who develop measles less than 2 years of age. It's a progressive neurologic decline, which generally leads to death within 3 years of onset. So preventing this delayed complication is essential as well. Once a person has clinical symptoms of measles, unfortunately, there is no treatment other than supportive care. There is no specific antiviral therapy for measles, and really we're using supportive care to help relieve symptoms and try to address any complications that may develop. There is a role for vitamin A in severe cases in children who require hospitalization, but this is a fairly unique case. So post-exposure prophylaxis, or PEP, can be given to certain individuals. So PEP can be given within the targeted window and may provide protection or shorten the course of symptoms. So one option is to administer the MMR vaccine within 72 hours of an initial exposure. Or you can administer immunoglobulin within 6 days of exposure. So who's most at risk for measles? So individuals with recent travel, people who are not vaccinated or who are under-vaccinated. That label under-vaccinated means that people have not completed the 2-dose series for the MMR vaccine. And this may be because they're in the middle of receiving their vaccine series, perhaps a small child or someone who decided to get vaccinated later in life, or perhaps an individual that received the first dose of the vaccine, but for whatever reason chose not to receive the second dose. Individuals with a weakened immune system, immunocompromised individuals due to chronic medical conditions or medications that they might be taking, small children and infants, especially those less than 1 year old, and pregnant individuals. So how does measles spread? We know that it is a highly contagious respiratory illness. It lives in the nose and throat of an infected person. And the virus's primary mode of transmission is by breathing in droplets when someone infectious coughs, talks, or sneezes. The virus can also spread by direct contact with infectious droplets that enter the air by coughing or sneezing, and the droplets go on to land on surfaces. Someone comes by, touches the contaminated surface, and then proceeds to touch their eyes, nose, or mouth, and then inoculates themselves. The measles virus can also remain suspended in the air for upwards of 2 hours. And it's so contagious that if one person has it, that one individual may spread it to and infect many other individuals. So let's take a look at that. So, as we talked about, one of the reasons that we worry about measles so much is that it is very transmissible. So looking at this graphic here, we can see that each individual with measles can infect somewhere between 12 and 18 other people. And so let's take a moment just to compare this to other infections like influenza or the flu. Common virus circulates mostly in the winter months. We've probably all had it at some point. One person with the flu will typically go on to infect 1 to 4 other people. And Ebola virus, so very scary hemorrhagic fever. This is even less transmissible. And each individual with Ebola typically only goes on to infect 1 to 2 other individuals. Now, you'll notice that there is some variability in these numbers. The transmissibility of viruses can be affected by a number of different factors, including the environment, crowding, or the particular strain of the virus. But what most importantly to take away from today's discussion is that these numbers can be reduced substantially by vaccination and other infection prevention and control strategies. So let's talk about vaccination recommendations. The MMR vaccine is very effective in protecting people against measles, mumps, and rubella, and protecting them and preventing the complications caused by these diseases as well. So 1 dose provides 93% protection against measles, while 2 doses provides 97% protection against measles. So that's really why we want to get individuals the 2 full doses. Now, it is typically administered to children. The first dose is typically given around 12 to 15 months, and the second dose given around 4 to 6 years old. And adults without evidence of immunity should get at least 1 dose of the MMR vaccine, but certain adults may benefit from both doses. Adults that are going to be in a setting that poses a high risk for measles, mumps, or rubella should make sure they have at least 2 doses separated by at least 28 days. These adults include students at post-high school education institutions, so people attending college or university, healthcare professionals, as well as individuals who are traveling internationally. Now, there are a few contraindications to receiving the MMR vaccine. So anyone who has severe immunocompromising conditions like people with cancer who are receiving chemotherapy, or individuals that are on long-term immunosuppressive therapy, individuals who have a history of an allergic reaction to MMR vaccine, and people who are currently pregnant. So we have another poll question. A person is more protected from getting measles when they receive 2 doses of the MMR. True or false? That one's maybe too easy for all of you. The answer is true. All right, so next we're going to talk about infection prevention and control actions that everyone here can take if we come across a suspected measles case. So measles prevention in the healthcare setting requires a multifaceted approach, including these 7 infection prevention and control strategies. But we do need to remember that the most important measure to prevent measles transmission in all settings is ensuring community immunization. So whatever we can do to encourage vaccine uptake will play the biggest role in preventing the spread and potential outbreaks of measles. So step 1. Ensure that all healthcare personnel are vaccinated against measles. So individuals who meet any of the following criteria are presumed to be immune to measles. So people who have written documentation of MMR vaccine administration. We do know that the effectiveness of the vaccine is higher when you've gotten both doses. If they have laboratory evidence of immunity with a positive IgG, if they have laboratory confirmation of having had the disease, or birth before 1957. Now, before the vaccines were available, nearly everyone was infected with measles during childhood. So the majority of people born before 1957 are likely to have been infected naturally and therefore presumed to be protected against measles, mumps, and rubella, just due to this, significant exposure in childhood. However, healthcare professionals born before 1957 who do not have evidence of immunity to measles should consider getting 2 doses of the MMR vaccine. So we want to minimize potential measles exposure within the healthcare setting. So what do we do if there is a suspected case of measles? We're going to walk through this. So let's start on the left-hand side of the screen. In the blue box labeled before arrival to the healthcare setting, expected. So this is when you have a heads up that a patient is coming in and you're potentially worried about measles. So someone calls your office, calls the emergency department, calls your urgent care, with symptoms suspicious for measles. We want to get as much information as we can over the phone. We're going to screen their symptoms, gather as much information about the timeline. As we talked about, the timeline is essential to find out when their symptoms started and potentially when their potential exposure happened as well. For people with signs or symptoms of measles, we want to give them really great instructions about how to get there, to avoid public transportation, ask them to wear a mask on their way to the facility and while they're at the facility, and to minimize the number of people that are accompanying them. We want to make sure we give them clear instructions about which entrance to use and what precautions to take, and let them know that when they arrive, if they don't have a mask on already, you'll be giving them a mask and you'll be taking them to a private room to keep them isolated for further evaluation and testing. And we do want to make sure that our healthcare professionals are wearing appropriate PPE, including an N95 or the respirator. Now, what happens if we don't know that the patient is coming? So let's look at the yellow boxes on the right-hand side of the screen. So in this particular case, we don't know that the person is coming. They show up at your clinic, urgent care, emergency department, and we're going to use our typical triage questions and stations for rapid identification and isolation of patients with potential measles. So similarly, we're going to use the signs and symptoms of measles to identify these individuals, give them a face mask, get the appropriate PPE with an N95 or other respirator for our healthcare professionals, and place the patient in isolation away from other people as soon as possible. So getting them out of the waiting room and into a private area. We want to make sure that we're using appropriate respiratory hygiene and cough etiquette, hand hygiene, and really following our triage protocols as closely as we can to minimize exposure to other patients and healthcare workers. We'll want to make sure that you post visual alerts near the doors about what precautions are being used and provide individuals with instructions about kind of what to expect. Also making sure that the healthcare providers who may come in contact with these patients know that we're worried about measles, so they know to take all the essential precautions. And if the patient requires transfer to a higher level of care, so that you need to transfer them from your urgent care to the emergency department, make sure that the EMS systems notify the receiving facility or the accepting physician in advance when transporting patients with known or suspected measles so that we're prepared for their arrival. So it will be important to adhere to both standard and airborne precautions for these people. If you've attended any of our prior webinars, standard precautions are essential to preventing transmission of infectious agents in all healthcare settings. This includes things like hand hygiene, use of proper PPE, making sure that you're donning and doffing the PPE correctly, putting the N95 or other respirator on properly such that it covers the nose and mouth and is snug, following respiratory hygiene to prevent reduce the risk of cross-transmission of respiratory illnesses. And for these patients with, airborne precautions, we want to make sure that they are in an airborne infection isolation room. So this was previously called a negative pressure room, but an air room is a type of hospital room designed to prevent airborne microorganisms that are in the room from entering hallways or corridors. It's a single occupancy room used to isolate individuals with suspected or confirmed airborne infectious diseases. And there are essential steps that our environmental services individuals that will need to follow when cleaning these rooms or turning them over, making sure that we know what cleaning agents to use and making sure that we understand the cleaning process and pattern to make sure that the room is cleaned in the appropriate way. We'll want to make sure that these signs are appropriately labeled outside the door so that healthcare professionals know what they need to do and in what order they should be doing it. So making sure that they're cleaning hands before and when leaving the room, putting on a fit-tested N95 or higher level respirator before entering the room, and then removing the respirator after exiting the room, closing the door, and keeping that door closed at all times. A few other notes about our standard and airborne precautions. Like we talked about, we really want to make sure that we're placing patients with known or suspected measles in our airborne infection isolation rooms as rapidly as possible, keeping their mask on when they're, around other individuals. But if they're alone in the airborne isolation room, they can take off their mask, the patient can, that is. If an airborne isolation room is not available, ideally, we're going to transfer the patient to a facility that has one as soon as possible. But in that period of time before transfer may be feasible, make sure that the patient is masked, that they're located in a private room with the door closed. We're going to want them to wear the mask for the duration of the time spent in that room. And ideally, we'll want to make sure that this room is outfitted with a HEPA filtration system. And then after the patient leaves the room, we're going to leave it vacant for about 2 hours to allow for any particles that may be suspended in the air to come down. So healthcare professionals without acceptable evidence of immunity to measles should not enter the room of a patient with known or suspected measles. So only healthcare professionals who have immunity, who've been vaccinated or who have evidence of immunity should be caring for patients with suspected measles. Regardless, we do need to have everyone wearing an N95 or other respirator to prevent them from getting sick. If you need to transport the patient with known or suspected measles within or potentially even between healthcare facilities, ideally, we're going to limit that transportation as much as possible, but sometimes it's essential to get particular diagnostic or therapeutic procedures that can't be performed within the room or the facility. So if that were to happen, make sure that the patient is wearing a face mask, use a transportation route and process that reduces as much as possible contact with other individuals that are not essential for the patient's care. And then, as we talked about, making sure that the receiving healthcare facility or professional understands what's coming and what they need to do so that they can be prepared. With respect to the duration for airborne precautions, if someone is hospitalized, we're going to have these patients remain in airborne precautions for 4 days after the onset of rash. Remember, we talked about the onset of rash is day 0. And then immunocompromised individuals who have measles should remain on airborne precautions for the duration of their illness. It'll be essential to manage visitor access and movement within the facility. If there are persons with measles in the community, say you're in a location where there's an outbreak, consider screening visitors for signs and symptoms of measles before allowing them to enter the facility. And we'll want to make sure that our visitors also are protected, that they have immunity to measles if they're going to be entering the room of an individual with known or suspected measles. We're going to limit visitors as much as possible who are necessary for the patient's well-being and care. And then really focusing on our environmental infection control. So standard cleaning and disinfection procedures, making sure that we're using our disinfectants appropriately and frequently applying them to high-touch surfaces or objects, letting it sit for the appropriate contact times, making sure that we're using EPA-registered disinfectants, and using them according to the manufacturer's instructions. And then the disposal of PPE is another really important point. So we want to make sure that these items are disposed of appropriately to prevent any additional spread of the virus. Okay, so managing measles exposure, we want to make sure that people have immunity, ideally, with vaccines or having been exposed previously. An exposure to measles in a healthcare setting is considered whenever someone is spending time well unprotected. So not wearing a mask in a shared airspace with a person who is infectious from measles at the same time, or if they enter a space that was recently vacated by a person who has measles, but they were in there within the prior 2 hours. So if an individual is exposed to measles, you want to determine their measles immunity status. So if it is an asymptomatic healthcare personnel and they have presumptive immunity to measles, you would simply implement daily monitoring for signs and symptoms from day 5 after exposure through the 21st day after their last exposure. They do not need any post-exposure prophylaxis because they already are immune, and there are no work restrictions, meaning that they can continue to work during this period, provided they are asymptomatic. If the individual is asymptomatic, but they do not have presumptive immunity, we would need to exclude this healthcare professional from work, and we would want to administer post-exposure prophylaxis. So remember, we talked about either giving the vaccine or immunoglobulin, and we're going to monitor for signs and symptoms of measles. Patients who are exposed to measles who do not have evidence of immunity need to be placed on airborne precautions for 21 days after their last exposure or until discharge from the healthcare facility. We'll want to make sure that we administer post-exposure prophylaxis. And then if they're being discharged from the healthcare facility prior to that 21 days being up, we'll need to notify public health authorities like RIDO to make sure that we're aware and can follow up on them. So in the event of an outbreak or an exposure involving large numbers of patients who require airborne precautions, you'll want to talk with your infection control team before patient placement to determine potentially alternative areas that we might be able to use. So sometimes we're able to cohort patients who have confirmed measles in particular areas of a healthcare facility away from other individuals, trying to minimize the risk of exposing immunocompromised patients as they're at higher risk of contracting the virus. You can potentially need to use temporary portable solutions such as exhaust fans or other engineering alternatives to convert areas that are not already negative pressure or airborne isolation rooms into areas that can be used for isolation. So depending on the number of patients in an outbreak, or if there's large numbers of patients exposed, we might need to be a bit creative with how we are doing our isolation and creating airborne isolation rooms. So number 6, train and educate healthcare personnel. So we'll want to make sure that healthcare personnel have specific education and training, including refresher trainings like today's, on preventing the transmission of measles. Fit testing for respiratory protection device is essential. This is something that is done on a regular basis, oftentimes yearly, to make sure that the respirator is both comfortable and provides the wearer with the expected level of protection. Each brand, model, size, they're all going to fit a bit differently, and healthcare personnel should be fit tested every time a change is made to the model, type, or size. Also, if your healthcare professional has any weight changes or facial or dental changes that might change how the respirator fits them, fit testing should be done again to ensure that it remains effective. Also, we need to make sure that our healthcare professionals are trained and can demonstrate competency on the use of appropriate PPE. So we want to make sure that you are donning and doffing your PPE appropriately as well. So number 7, the last step, implement policies that alert key facility staff, including hospital leadership and your infection control teams, labs, frontline staff, about patients with suspected or known measles. So we want to make sure that we're communicating and collaborating with our public health authorities and colleagues, and allowing notifying them of any potential patients with known or suspected measles. You'll want to make sure that there are specific persons designated within your facility that are responsible for communication with the public health officials and also disseminating information to other healthcare professionals that are working there. So, kind of summarize the 7 steps that we just talked about. These can kind of fall into 3 main categories. We want to identify, so rapidly assess symptoms, age, travel history, vaccination status, exposure to potential known measles cases. We want to isolate patients that we are concerned that may have measles, as opposed to allowing them to remain in the waiting room, isolating them with airborne rooms and making sure they have a mask on and making sure that the healthcare professional is wearing the appropriate PPE. And then inform your local or state health departments about suspected cases. So within Rhode Island, our healthcare professionals have a great resource here at the Rhode Island Department of Health. If you have any suspected cases of measles, give us a call. We'll make sure we put the phone number in the information for you. And our nurses can help with rapid testing and investigation. It is an immediately reportable disease here within Rhode Island. So that means that providers must call immediately upon suspicion. And the team at the Rhode Island Department of Health will work with you to make sure that you're getting the right swabs and testing and to do any contact tracing should that be necessary. All right, we've got a poll question. So if someone is suspected of having measles, should you isolate that person promptly? Yes or no? Awesome. 100% said yes. We should. We want to get them isolated with a mask on and prevent them from sharing potentially the virus with anyone else. All right, one more poll question. What precautions should be used when caring for a person with measles? Standard and enhanced barrier precautions, standard and droplet precautions, standard and airborne precautions, or standard precautions only. Okay, so the answer for this is standard and airborne precautions. Remember, we talked about being in an airborne isolation room. Enhanced barrier precautions is something different, mostly used in our long-term care facilities. All right, so I think we have 2 case scenarios to briefly go over, and then we'll wrap everything up. Invite you to participate. You can put any answers in the chat box, and I'll try to monitor that as well. So case number 1, 23-year-old male arrives to the emergency room with complaints of fever, cough, and watery eyes that started at the end of his college spring break. The healthcare professional noted small raised spots at the patient's hairline. So first question, what are some immediate questions that the physician or healthcare professional should ask the patient? You can put any answers in your chat box and I'll pull that up. So what do we want to know? So remember, we talked about the timeline is essential to figuring out if this may be measles. Figuring out when a potential exposure was, how many days ago. Measles follows a very predictable pattern, as we're talking about, timeline from exposure to onset of symptoms. All right, next question. What are some infection control actions that the healthcare professional should take? Isolate the patient, put a mask on. Airborne isolation room, excellent. PPE for the healthcare provider, closed door private room. Great. We want to know that the healthcare provider also that's taking care of them is immune to measles, right? We want to make sure that we're not putting any of our colleagues at risk. We want to keep them in the room, keep the mask on them, making sure our colleagues have the appropriate PPE as well. Great. Okay. Case number 2. Mother called the pediatrician's office to report that her 3-year-old daughter had a fever of 105 Fahrenheit, accompanied by cough and runny nose. She reports that her daughter's symptoms started a few days after they returned from Disney. So what are some important triage questions to ask the mom? So vaccination status, anyone sick, other symptoms, rash, date of travel to get the timeline. Great. That's what I was going to say. We need a timeline regarding the onset of these symptoms. Any rash? Good. Okay. And then what pre-arrival instructions should the healthcare professional give to the mom? So say she's going to come into your clinic, your outpatient clinic, so that you can evaluate them, right? Kids often get high fevers and cough and runny nose, super common symptoms. What do we want to tell them before they arrive? Okay, we want masks on them, both mom and kid. We want PPE for our healthcare professionals. Use a private entrance. Great. Call when they arrive. So staff can have PPE on. Perfect. Don't sit in the waiting room. Don't use public transportation. Awesome. So interestingly, Disney has been implicated in more than a few outbreaks of measles over the last 2 decades. If you think about it, people travel from all over the world to go to Disney World and Disneyland. And you're in kind of close quarters with people waiting in a line. So a number of them have been linked to visits to Disney. All right. So great job participating in those questions. Thank you. All right, so we have reached the end. We're going to go over our key takeaways. So we have 5 of them. Measles is a highly contagious febrile illness that can cause serious complications and may result in death. Identifying measles early is critical to preventing the spread of the virus. The most important action, the most important to prevent the spread of measles is vaccination. Suspected cases of measles should be masked and isolated while the medical evaluation is performed. And healthcare professionals should follow standard and airborne precautions when caring for an individual with measles. So, few things before we go today. These are 2 posters available from CDC. You can download them and print them for your staff. The poster on the left is identifying a rash kind of in general and how to protect against infection. The one on the right is a summary of key points regarding measles, and images are there to help with rash identification, and we will put links for these 2 posters in the chat. Here's some information about where to find us. So we are on social media channels. We have a website that lists our upcoming events. We'd love to see you interacting with us on social media. And here are 2 upcoming sessions that we have. They're both being offered in Spanish about cleaning and disinfection for EVS personnel. We will be offering continuing education and certificates of training for these 2 sessions. You can pre-register online, and Abby will show the link to do so. Here's some references that we used for today's webinar. And then just a few things regarding the certificate of training and CNE. So in order to receive your certificate of training, you must complete the pre-session survey before we started, participate in today's session, and then complete the post-session survey. So a link for the post-session survey will be sent to you via email tomorrow, May 6th, and it will be available until May 10th at midnight. So once you complete the requirements for the certificate of training, it will be emailed to you in a PDF on May 13th. In order to receive continuing nurse education, you also need to complete the post-session quiz. And then for EMS and dental providers, you can use this as 1 hour of continuing education credit. All right. Take a minute to complete our end of session feedback poll that's on your screen right now. Short 3 questions. These help us, improve our sessions moving forward and making sure that we are getting you the resources and educational material that you find helpful. And as we're finishing that up, we will also have, I think we have 1 or 2 minutes for any questions or clarifications. Feel free to. So just some clarification points about the transmission. There's some questions in our Q&A right now. Transmission is airborne, so it can remain suspended in the air for upwards of 2 hours after the person has vacated the room. Very small particles, as opposed to flu, which is going to be droplet, right? Larger particles, doesn't travel as far, doesn't remain suspended in the air in the same way. And COVID is kind of a hybrid, right? It has some properties that behave more like our traditional airborne thought process, and others that that act a bit more like our historically kind of considered droplet. But basically, breathing in any sort of respiratory particles is what transmits the virus. It can live on surfaces, which is why it's super important to make sure that high-touch areas and the rooms are cleaned appropriately with our EVS colleagues as well. Question about how long does the virus last in a host? I'm guessing this means how long they're infectious for. So remember, 4 days before the onset of rash to 4 days after the onset of rash. Symptoms may last, the person may be sick for longer than that, right? With fevers or any sort of complications. That's going to be, kind of dependent on what happens with that individual. But the time that they're infectious is going to be 4 days before the onset of rash to 4 days after the onset of rash. All right, we are just at 1 o'clock. Thank you everyone for joining us today. Super excited to have you here. Of course, feel free to reach out after today's session. If any questions come up, we're always available to, give any guidance, come to your facilities, help out with anything that we can. So feel free to reach out and hope to see you at a future training. Thanks so much.